Today I have told you about ontogeny of the hemoglobin synthesis, how hemoglobin synthesis starts, right? So hemoglobin synthesis starts during the embryonic life, right? Embryonic life, it is called as embryonic hemoglobin. Embryonic hemoglobin is present up to 8 weeks. Already I have told you 8 weeks of intrauterine life, right? So embryonic hemoglobin up to the 8 weeks of intrauterine life, and these are four in number, right? Gower 1, Gower 2, right? Portland 1, Portland 2. So Gower 1, Gower 2, Portland 1, Portland 2. Already I have told you all these things, right? Gower 1 is having two important. So all these are, two things, they will be having pair of genes, right? Pair of chains, and they will be also in pair, right? So same we are seeing here. Gower is having two chains, that is called zeta chain and epsilon chain. So two zeta, two epsilon. So I can see that Gower is having this is called zeta chain, right? So this is called zeta chain, zeta 2, and this is epsilon 2, right? So zeta 2, epsilon 2. This was the question also in AIMS exam, right? So zeta 2, epsilon 2 is a embryonic hemoglobin. So that was the question, simple question, right? Now look at the Gower 2. What is Gower 2? Gower 2 is simple alpha 2 and epsilon 2. Gower 2 is alpha 2, epsilon 2, Portland 1 and Portland 2. Now you can see the order. This is the in order, right? First will be Gower 1, then Gower 2, then Portland 1, then Portland 2, right? Gower 2, alpha 2, epsilon 2. Portland 1 is zeta 2 and gamma 2, right? Portland 2 is zeta 2 and beta 2. So zeta is looking like a jalebi. So like that I had told you, you can remember, right? Jalebi like dikha. So wo zeta chain hai, zeta 2, right? Zeta 2, beta 2. So Portland 2 is zeta 2, beta 2, right? So these are the embryonic hemoglobin, and all these are formed up to the 8 weeks of intrauterine life. 8 weeks of intrauterine life. That is very important. Intrauterine 8 weeks, right? Now coming to the fetal hemoglobin. After that, means after 8 weeks of intrauterine life, now there will be synthesis of fetal hemoglobin, right? What is fetal hemoglobin? Again, paired hemoglobin chain, that is alpha 2 and gamma 2. So alpha 2, gamma 2 is the fetal hemoglobin. That is another important fact we have to remember. Before I move ahead, because in hemoglobin disorders, when we will discuss about the thalassemias, that time it will be quite helpful to know that what is the normal adult hemoglobin composition, right? So I am showing you normal adult hemoglobin composition. So what is the composition of the normal adult hemoglobin? Right, so this is the composition of the normal adult hemoglobin. So what is that? HbA is maximum, HbF and HbA2. A is adult hemoglobin, F we all know, fetal hemoglobin. A2 is minor hemoglobin. So remember, A2 is sometimes also called as minor hemoglobin because it is seen in thalassemia minor, right? So it is also called as minor hemoglobin, and it is very important for the diagnosis. So what is HbA? So normal adult hemoglobin is 2 alpha chain, 2 beta chain. That is again a very important thing to remember, right? So normal adult hemoglobin is 2 alpha and 2 beta chain. And how much is normal concentration? It is 96%, right? So HbA is alpha 2 beta 2, and normally it is present in our human body is 96% of composition, right? Whereas fetal hemoglobin is less than 2.5%, and that is alpha 2 gamma 2 already I told. Alpha 2 gamma 2 is the fetal hemoglobin less than 2.5%. There was a question in the state exam long back in 2015, right? That adult hemoglobin in adult hemoglobin level. So what is fetal hemoglobin? Fetal hemoglobin will reach to the adult hemoglobin level. To the adult level. So this is the adult level. In adult also you will be seeing the same thing. That is what I am talking about, adult, right? So fetal hemoglobin will reach to the adult level by what age of the baby? Because initially it will not be the, initially fetal hemoglobin will be normal. It will be high. But after some months of the birth, they will become normal. So what is that time? So here it's very, very important because I'm saying why? Because this is the line of Winthrop, and Winthrop says that they will reach to the adult level. Remember, fetal hemoglobin will reach to the adult level by the age of 6 to 7 months of neonatal life. Neonatal. Please do remember this thing because I have seen many places, many guidebooks, they are writing, some 2 months, say 1 month or 9 months like that, or 18 months, because those were the options in exam also. So this was the question in one of the state exam, right? And whatever I have written is the line of the Winthrop. So that is the important thing you have to remember. There is no deviation from this point, right? So fetal hemoglobin will reach to the adult level. What is adult level? Less than 2.5%, right? Less than 2.5%. By what time? By the age of 6 to 9 months, right? By the age of 6 to 7 months, right? So infant life. That's what I'm saying. Neonatal life means infant life only, right? Infant means I think 1 month only, right? Neonatal means neonates. Whatever means, it's 6 to 7 months after the birth. Remember, because my pediatric is not very good, so nothing to discuss and mess up with you people, right? So fine, it's okay. So after birth, 6 to 7 months, it will be increased, and after 7 months or 6 to 7 months, it will become normalized. Means it will reach to the adult level. And what is adult level? Less than 2.5%. Clear? So now you understood. Adult hemoglobin 96%, fetal hemoglobin 2.5%, and minor hemoglobin, which is alpha 2 delta 2. That is also very, very important. Alpha 2 delta 2 will be less than 3.5%. Clear? So that's all. Now we will be moving to the hemoglobin disorders. So when we are talking about hemoglobin disorder, they can be of two types. Either it is a qualitative or it can be a quantitative. Right? Qualitative or quantitative. I'll be telling you when time will come. I will tell you. Don't worry. When time will come, then I will tell you. That I told you normal thing. First you remember normal. Right? Qualitative and quantitative. Quality means what? See, there are two chains, alpha and beta chain, right? In hemoglobin, in alpha and beta, in hemoglobin there are two chains, right? They are paired one. So what is the meaning of the qualitative? Qualitative means what? Qualitative means the quality of hemoglobin is altered. Quantity is not altered. The quantity is not altered. Quality has been altered. So maybe alpha chain and beta chain, if you are seeing the quantity, it is same, but quality has been altered. Probably one type of amino acid, maybe the positively charged amino acid has been replaced by negatively or reverse. Right? So one amino acid would have been changed, or there will be some change, but not the concentration, not the quantity. Right? So the great example is sickle cell anemia. Right? So sickle cell anemia, we all know that is glutamic acid is getting replaced by valine. Right? So here quantity of beta chain is not getting decreased. Quantity of beta chain is same, but quality has been altered. Previously it was soluble because of glutamic acid, and now it is becoming insoluble because of the valine. So quality has been altered. I understood. So sickle cell anemia is a qualitative, whereas when you see alpha chain is getting decreased, that is called as alpha thalassemia. So here quantity is getting decreased. Remember here quantity is getting decreased. Alpha chain quantity, and when there is a decrease in the beta chain quantity, that will be called as beta thalassemia. So whatever chain is getting decreased, that will be the name. Alpha chain decrease, alpha thalassemia. Beta chain decrease, beta thalassemia. So I understood. So these are quantitative hemoglobin disorders, right? What else we need to remember here? Just few important things which I wanted to let you know. Sickle cell anemia. What is the most common genetic change? What is the most common genetic change? Right. So one of the very important questions. What is the most common genetic change in alpha thalassemia? Right. What is the most common genetic change in the beta thalassemia? So alpha thalassemia and beta thalassemia, what are the genetic changes? Right. So in sickle cell anemia, most common genetic change is the point mutation. Point mutation. Alpha thalassemia, most common genetic change is deletion. Beta thalassemia is again point mutation. Right. Okay. So now what we are observing, that sickle cell anemia and beta thalassemia both are having same problem, point mutation. Both are having same problem, and that is the point mutation. Right. Both are having point mutation. So what is the difference? What is the difference here? Sickle cell anemia. Remember, this is the mnemonic. Sick will miss. Right. So this is the mnemonic of sickle cell anemia. Sick will miss. So sickle cell anemia will be having missense type of point mutation. So what kind of point mutation? Miss. Sick will miss. So it will be having missense type of point mutation because in this sense has been changed. Try to understand. Sense has been changed. I'm just writing it short. I will be writing detail later on. See, the glutamic acid has been replaced by valine. right? Glutamic acid is, some other charge, negatively charged, and valine is the neutral, right? So that is why the sense has been altered. Now can you notice the sense has been changed? Glutamic acid was something else, valine is something else. Glutamic acid was soluble, valine is insoluble. So sense has been changed. So it is called as missense point mutation. Whereas beta thalassemia is because of the non-stop codon, or you can say that nonsense codon. So stop codon or nonsense codon, not non-stop, stop codon or nonsense codon, right? So these are called as, see, this is the missense point mutation, and this is, what is the beta thalassemia point mutation? Yes, UAG. Is that in PMT also you studied, right? So this is called nonsense, because they're not creating any sense. That is why nonsense point mutation, right? So now you got this clear. So these are the two very important things. Missense point mutation is seen in sickle cell anemia. Nonsense point mutation because of the stop codon or nonsense codons, right? UAG or UG. Clear? So these are the basic differences, right? And remember, both of these hemoglobin disorders are autosomal recessive, right? Both are autosomal recessive. And out of all the hemoglobinopathy, which is the most common hemoglobinopathy? That was the NEET PG question in 2017. So most common is the thalassemia. Never say that it is never go for the sickle cell anemia. And in thalassemia also, which is most common, it is beta thalassemia, which is most common, right? So always remember, hemoglobin disorders or all these hemoglobinopathies are autosomal recessive, right? They are autosomal recessive, and most common hemoglobinopathy is thalassemia, beta thalassemia, right? So now we will start one by one. First we will start from the sickle cell anemia. So here I'm writing sickle cell anemia. What is sickle cell anemia? It is an autosomal recessive disorder, right? So whenever you are going to represent them, so it will be represented by SS. Both will be homozygous, right? Sickle hemoglobin homozygous. So this will be called as sickle cell anemia or disease. What you will call this one? HbSA. Can you see? This is normal hemoglobin and this is the sickle hemoglobin. So what is this? Sickle cell carrier or trait. Autosomal recessive, they should have the trait. If child is having some problem, then they should have a uniparental trisomy. You have read in genetics. I have taught you, right? Sickle cell carrier, right? Autosomal recessive, whatever the trait of autosomal recessive, they will be following. If there is a uniparental trisomy, then they will be having one affected parent, one is carrier parent, right? So I think I have taught all these things in genetics also, right? If you have not seen that lecture, please go and see that. Genetics is very beautiful. You'll understand many concepts, right? So sickle cell carrier or sickle cell trait. So remember, carrier and trait, many people they mistook it, right? They feel that carrier and trait, they are same thing. Remember, this is the nomenclature I'm saying. Carrier and trait are not same. This is the nomenclature which is same in case of sickle cell anemia. Otherwise, it is not the same. I will show you during the alpha thalassemia that carrier is something else, trait is something else. So only for the sickle cell, carrier and trait both are same. Clear? So sickle cell carrier or trait is heterozygous. So now you can see that homozygous is disease, heterozygous is carrier. Clear? Right. Now what is the problem in sickle cell anemia? Sickle cell anemia, if you look at the pathogenesis is the point mutation. Already I told you what kind of mutation you are seeing. Sickle cell carrier, what kind of mutation you are seeing? Yeah, it's a missense type of point mutation, right? Missense point mutation, right? So why it is called as missense point mutation? Because you can see the beta chain of hemoglobin, and in beta chain also 6 positions. Remember, beta chain 6 position of hemoglobin. Glutamic acid will go away. Remember, this is the mnemonic G for go away. So it will remove, and who will enter? If you change the A from I, it will become villain. So villain will enter. So go away, villain will enter, or V for welcome. Also you can say that villain will enter or V for welcome, right? Right. So now we can see that glutamic acid has been formed, and glutamic acid is, I think I have written positive this. Okay, let me change this. Glutamic acid is negatively charged, polar and soluble, right? So it is negatively charged, polar and soluble amino acid, which has been replaced by non-polar and neutral. Zero means neutral. So now can you see this? What has been removed? It has been removed. What has entered? Valine has entered. So valine containing hemoglobin is HbS. So now understood. In HbS, what will be present? Valine will be present. And what is valine? It's a neutral, non-polar, insoluble, right? So now you understood what is happening. This missense point mutation. So you understood why we were calling this as a missense point mutation. Now you understood why sickle cell anemia is having missense point mutation, because sense has been altered. Sense has been altered from polar to non-polar, from soluble to insoluble, from negative to neutral. Clear? Right? So now you can see that HbS has been formed, which is containing valine, and they are insoluble, non-polar. So examiner had asked this question, right? During this sickle cell anemia, hemoglobin formation, what is altered in hemoglobin? Stability or solubility? So now you understood HbS, what is altered? Solubility is altered. Right? So that is the other very frequently asked question in exam. What is altered in sickle cell anemia? So remember, sickle cell anemia, it is solubility which has been altered. Right? Fine. So what will happen because of this? Right? Because of this, now try to understand. Now hemoglobin S, that sickle hemoglobin, whether it is in oxygenated form or deoxygenated form, anything. Deoxygenated means under hypoxic condition. Whether it is having good oxygen or low oxygen, in all cases of the sickle hemoglobin, they will be having a permanent sticky site. That is the very important thing you have to understand. That is the very, very important point I'm telling you. You have to understand whether it is oxygenated or deoxygenated. Means in all situations, HbS hemoglobin, sickle hemoglobin will be having a sticky site. Right? So sticky site will be always present. Clear? If you understood this point, now we'll move ahead. What will happen during the sickle cell anemia? See what happened in oxygenated, deoxygenated, both conditions, they are having a sticky patch or a sticky site, right? What will happen in the hypoxia? When there is a hypoxia, right? Hypoxia means low oxygen. Now we are talking about low oxygen. What is going to happen? Right? Low oxygen. See that in low oxygen also it is present. In normal oxygen also it is present. But when there is a low oxygen, what extra thing will be expressed? That is the complementary site. I understood. That is what I was showing you here. Under oxygenated, deoxygenated, both conditions, you will be saying sticky. So sticky is always there. So we can remember like this. S will be having S. HbS will be having S always. Right? So sticky site is always present. So what is expressed during the hypoxic condition? During hypoxic condition, they will express the complementary site, right? So complementary site has been expressed under the hypoxia. So because of this, what is happening? Complementary site, which has been expressed now, is going to combine with the sticky site. So this combination will be going on. Can you see? Now the complementary is combining with sticky site of another hemoglobin. Complementary is combining with sticky site. Sticky is combining with complementary. So this, what is happening? What is happening now? What is happening? Because of this chain is getting elongated, right? CS, 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 and this process is called as polymerization of hemoglobin. So I understood. So what I'm saying is that during hypoxic condition, complementary site will be expressed, and this complementary will combining with the sticky, or sticky will be combining with the complementary, and this will cause polymerization of the HBS. This polymerization of HBS will convert the hemoglobin into a needle shape. Needle-like hemoglobin crystals are formed. Right? So because of this process, what is happening? Because of this polymerization of the hemoglobin S, now needle-like hemoglobin crystals are formed. What they are going to do now? This needle-like hemoglobin crystal, they will change the shape of RBC. So now they will be changed. So what will be the shape of RBC now? Now RBC is like this. Right? So because of this needle-like crystal, they have acquired the sickle shape or crescent shape. That is why it is called as sickle cell, or also known as drepanocyte. So remember, both are same name, drepanocytes. Right, so always remember this point. Sickle cell or drepanocyte, both are same thing. Simply examiner can ask you a question, right? Where you will see drepanocyte. So that time you have to know that sickle cell is the another name of drepanocyte. Right? Fine. So I understood what has happened in this pathogenesis hypoxia. Complementary site has been expressed. Complementary will combine sticky will combine complementary, and this will start polymerization. Polymerization of hemoglobin will convert them into the needle-like crystal, which will distort the shape of RBC into a sickle or drepanocyte. Right? Clear? Now come to the this picture. This is the picture peripheral smear where you can see these are the sickle cell. Right, so can you see both shape or crescentic shape sickle cells or drepanocytes are visible. Now I want to put your attention at this cell. Can you see this? What is this cell? Which I mark here? What is that cell? This cell is called, very good, this is called target cell. This is called target cell. When you are seeing RBC, you should see normal central pallor, but there is a hemoglobin in the center part. So this looks like a target, right? So this looks like a target cell. So where you will see target cells? So just remember this easy way to remember, right? It will be seen in hemoglobin disorder, and it will be seen in nutritional anemias. Simple. Hemoglobin disorders and nutritional anemias. So which hemoglobin disorder? Which hemoglobin disorder you will see them? Which hemoglobin disorder? Sickle cell anemia, thalassemia. Which nutritional anemia? Iron deficiency anemia, megaloblastic anemia. So now you got this. There are 4 important causes of target cells. So that was the question also in EPG exam. Examiner had asked this question, right? Target cells are characteristic of which of the following condition? And all 4 options were given in exam. So that is why I wanted to say that, right? So they are most characteristic or most commonly seen in thalassemia, right? So out of all these reasons, target cells are most common or most characteristic in case of thalassemia, right? So this point you have to remember. So now in this peripheral smear, we are seeing sickle cells and we are seeing target cells, right? So target cells can be seen in all these conditions, but they are most commonly associated with the thalassemia, right? Clear? Right. Now we will see what happens because of the sickling. What happens because of sickling, right? So whenever we are seeing a sickle cell, can you see these are the 2 sickle cells which I am showing you in this picture? These are the 2 sickle cells, right? And during hypoxia or deoxygenated condition, when there is a hypoxia, there will be increased expression of the adhesion molecule on sickle cells, right? So there is an increased expression of adhesion molecules on sickle cell. So because of these adhesion molecules, what is happening? All these sickle cells are getting attached to each other. So because of this attachment, can you see this is the blood flow? Can you see this is the blood flow? And because of this, now you can see the blood flow has been obstructed, right? Blood flow has been obstructed. So this distant organ is getting ischemia, right? So what I'm showing you, because of these RBCs are sticking to each other and they're blocking, they're forming the thrombi. So they're forming the thrombi, right? So these thrombi are causing ischemia, leading to infarction, right? And finally, this distant organ will be affected. So this is what is distant organ: ischemia, infarction, because there have been no blood supply or low blood supply, right? So this organ is showing ischemia, infarction, and finally they will be converted into fibrotic changes, fibrosis. So now you understood this is what called as. Can you see this? What is happening? The blood vessel is getting obstructed. Can you see this? What is happening in this entire scenario? Blood vessel is getting obstructed. So that is called as vaso-occlusive, right? Vaso-occlusive, because blood vessel is getting obstructed. What is happening? What is happening because of this obstruction? This organ is getting compromised. What is happening? Ischemia, infarction, and fibrosis. So what is known as vaso-occlusive organ is having crisis, vaso-occlusive crisis. So this process is called as vaso-occlusive crisis. And remember, vaso-occlusive crisis is the most common clinical finding in sickle cell anemia. Right? Clear? So now you understood this concept. Because of the adhesion molecule, now RBC will attach to each other. They will attach to the vessel wall, and this will form the thrombi. Right? So RBC is forming thrombi in the blood vessel wall, stopping the blood flow to the distant organ, and because of this thrombi, causing blockage leading to ischemia, infarction, and fibrosis. Right? So this process is called as vaso-occlusive crisis. And vaso-occlusive crisis is the most common clinical finding in the sickle cell anemia. Clear? Right. Now we will see what are the factors which will affect sickling. Right? What are the factors which will affect sickling? So this is again a very, very important thing. I will come back to the vaso-occlusive crisis. Don't worry for that thing. I have just given you an introduction because you were seeing the sickle cell, and I wanted to show you what will be the consequences of the sickle cell formation. Now we will see what is the most important factor for the sickling. What is the most important factor for sickling? Hypoxia or HBS concentration? Hypoxia or HBS concentration. See, even if I'm feeling hypoxic, will I get the sickling? Will I get the sickling? Yes or no? I will not get sickling. Why? Because I do not have HBS. Understood? So what is the most important factor? Hypoxia is not the most important factor. This is a very important MCQ in exam, right? Most important factor, remember, it is the HBS concentration. HBS concentration is more important than hypoxia. Please keep that in your mind, because जब HBS ही नहीं होगा तो फिर क्या फायदा है? How this hypoxia will be causing, right? So now understood. So HBS concentration is the most important factor, right? But this point should not be confused with the HBSA. What is sickle cell? HBSA is sickle cell carrier. Sickle cell carrier, there is no sickling. That was the question in the NEET exam, right? And NAIMS exam. These are very favorite question of the examiner. Why there is no sickling in sickle cell carrier, right? Because in sickle cell carrier, when you are going to analyze the HBS and HBA, so HBS is less than 40% and HBA is more than 60%, right? So examiner will be giving you 2 options. In sickle cell carrier, there is no sickling. In sickle cell carrier, we are talking about no carrier. Carrier is having no sickling. Why? Because of the low HBS concentration or because of the HBA inhibits the polymerization? What should be the right answer? Can you tell me in the comment box? Yes, very good. So answer is because HBA inhibits polymerization of HBS. So this is the right answer, right? So now understood. This is the right answer. It is inhibiting. HbA is inhibiting the HbS polymerization. Why? Why? Can you see? Can you remember that thing what I have told you? HbS, चाहे वो कोई condition, oxygen or without oxygen, they will have one permanent sticky site, right? Complementary will be expressed when there is a hypoxia, right? And that will combine with the sticky. But what is happening? What is happening if it is HbA? If it is a HbA, so HbA is having receptor already for the sticky patch. So that is the important thing you have to remember, that HbA is having. I'm just writing here. HbA is having receptor for sticky site of HbS. Receptor for sticky site of HbS, right? So what is happening? This receptor is combining with sticky site. That's all. Can you see this? Now there is no polymerization. So that is how they are inhibiting polymerization of the HbS. Now you understood this point? This line is given in Robbins also, right? So while reading, you may not be understanding. That is why I took this concept here and I wanted to explain like this, right? So can you notice this? What is happening here? That sticky is combining with receptor. So HbA ka jo receptor hai, HbA receptor is going to combine with sticky patch and then they will block them at this stage. Now there is no, if you express complementary here, then there is no use because receptor will combine with only with sticky. So that's all. They will inhibit the polymerization. So by this mechanism, HbA inhibits the polymerization. Clear? So by this mechanism, HbA inhibits the polymerization of HbS. Clear? Right? Same thing you will see in case of fetal hemoglobin also. Fetal hemoglobin also does the same thing, right? They will inhibit the polymerization. So now understood, most important factor HbS concentration. Most important factor is the HbS concentration, right? More important than hypoxia. Sickle cell carrier, there is no sickling because HbA inhibits the polymerization of HbS because receptor combines with the sticky patch only and they will not combine with the complementary patch, and by this mechanism this will inhibit the polymerization. Same is done by HbF also, right? So that is why fetal hemoglobin. So we are talking about factors affecting sickling. So fetal hemoglobin, what they are going to do, they are also going to decrease the sickling, right? So that is why when you are seeing a sickle cell anemia patient, right? Will you find symptoms in the sickle cell anemia patient who are less than 6 months old baby? No. So that's fine. You remember what I have told you? Adult hemoglobin. The fetal hemoglobin will reach to the adult level. Reach to the adult level by what months? 6 to 7 months. Right. So now understood why I was teaching you that time, because till this time patient will be asymptomatic. Understood? So because of the fetal hemoglobin level is high, until this time patient will be asymptomatic. So anemia, jaundice, or any other symptoms will appear after 6 to 9 months. Right. So now understood this point clearly or not? Everybody, because this question has been asked in AIMS exam in various form. So always remember this point: sickle cell anemia, that anemia, jaundice symptoms will appear after 6 to 9 months. Why? Because fetal hemoglobin will reach to the adult level by 6 to 7 months, and by this duration they will be asymptomatic because fetal hemoglobin decreases sickling. Clear? So now understood. So always remember, if examiner says this word, right, that sickle cell anemia patient died because of jaundice and anemia by the age of 3 months, so that will be a false statement. Now understood. Anemia, jaundice will not happen before 6 months. Right? Before 6 months, it will not happen. Why? Because of the fetal hemoglobin is inhibiting sickling. Why? Because fetal hemoglobin is combining with the sticky patch and inhibiting the polymerization of the sickle hemoglobin. Right? I understood this point. Let us see what will happen here. Can you tell me what will happen if there is a HbC and this anemia is called as this thalassemia? This anemia is called as HbSC anemia, another variant of sickle cell anemia. So in this, what will happen? More sickling or less sickling? See this HbC will remove water and sodium. Right? So what is HbC hemoglobin? SC hemoglobin has a tendency to remove water and sodium from the cell. So they have removed it. So as a result, what is happening? HbS concentration inside the RBC is getting increased. So because of increase in HbS concentration, there will be increase in sickling. Right? So now understood. So in this patient, HbC will increase the sickling. Right? And there was a question in Chipmer and NEET PG both exam, and this was repeated in previous Chipmer exam also. This HbSC disorder patient has a characteristic presentation of the proliferative retinopathy. So increased proliferative retinopathy incidences are characteristic of which variant of sickle cell anemia? That was the question in Chipmer and NEET PG exam. So remember, HbSC is having increased incidences of the proliferative retinopathy, or right? So now understood. So this HbC is present in HbSC, and this patient is having increased incidences of the proliferative retinopathy, and this is the more characteristic. It is more commonly seen in here in comparison to the sickle cell anemia. Now you understood. That was the question in the Chipmer and NEET PG exam, and previous year it was repeated. So it's a good question which examiner can repeat again, right? Fine. Now coming to the next one. See this: whenever MCHC increases, right? What is MCHC? Mean cell hemoglobin concentration. Which hemoglobin we are talking about? Which hemoglobin we are talking about? Here, HbS, right? So MCHC increase means HbS increase. MCHC means HbS is getting increased. Sorry. Right? So when we talk about increase in MCHC, so means HbS is getting increased. So whenever MCHC is getting increased, HbS will be getting increased, and because of this increase, what will happen? There will be more sickling, right? So now you understood. So whenever there is an increase in MCHC, there will be increased HbS, increased sickling. So what are the other conditions where MCHC can be increased? So in dehydration, because water has been removed. So basically, water is removed from where? From the intravascular compartment and from the cells also, right? So from the RBC, when water has been removed. So you remember what has happened here? Water has been removed. So if water is removed outside, so HbS concentration will be increased. So that is what we are seeing here also. During dehydration, MCHC will be increased, and there will be increased HbS concentration, and that will be promoting more sickling, right? Another important thing. This question has been asked in previous year NEET PG exam. What will happen if there is an acidic pH? See, try to understand what happens in acidic pH. What has happened? You remember? Yeah, very good. If there is a hereditary spherocytosis, they will have this kind of increase in MCHC, right? And I'll just tell you one more example here. Right. So here, what I was telling you, this was the question, right? What is the relation with the pH? So when examiner is asking relation with the pH, don't remember that thing. Just remember, under hypoxia there is more sickling, right? Under hypoxia there is more sickling. Why? Because when there is hypoxia means what? We are getting more carbon dioxide. That is what the hypoxia says. If we are having hypoxia, it means we are having more carbon dioxide concentration, and carbon dioxide will be converted into bicarbonate. Bicarbonate will break down, and they will be forming H plus and SiO3 minus, and this H plus increases acidic pH. So I understood. If there is more hypoxia, there is more acidic pH. So I understood. There is more acidic pH means there is a decrease in pH. So I understood this point or not? This is very easy. So you need not to mug up. You need not to mug up about the pH. You just remember this concept that there is oxygen. There is a decrease oxygen means increase CO2. Increase CO2 means increase bicarbonate. Bicarbonate increase means there is a more H plus, and because of more H plus, there will be more acidic pH. More acidic pH means decrease in the pH. Right? So decrease in pH will be increasing sickling because hypoxia increases sickling. So here I will write because of hypoxia there is decrease in pH. I understood. Because of hypoxia there is decrease in pH, which is called acidic pH, and acidic pH will increase the sickling. MCHC see mean cell hemoglobin now. Mean cell hemoglobin concentration. Hemoglobin. Mean cell hemoglobin concentration. C is concentration. Which hemoglobin? If there is a sickle hemoglobin, so HPS is getting increased now. If there is a MCHC means what? Mean cell hemoglobin concentration. Hemoglobin concentration. So what hemoglobin? Either it is HbS hemoglobin. So whenever sickle cell anemia, MCHC is getting increased, there will be a more sickling, right? And during dehydration, water will remove. During dehydration, water will remove. So hemoglobin concentration will increase because gram is more, deciliter is getting less. Understood? Gram is more, deciliter is less. So MCHC is increased. More sickling. Clear? Now coming to the point, right? Sickle cell anemia, right? When we talk about the sickle cell anemia, they have three important. There are so many things written in the books, right? So I wanted to make it very simple. I wanted to stick to the important one. So there are three important crises: vaso-occlusive crisis, aplastic crisis, and sequestration crisis. Three important crises we need to remember. Vaso-occlusive crisis is the most common, as I have told you in the beginning also, right? So this is the most common crisis or most common clinical feature in the sickle cell anemia, right? Aplastic crisis is same as, so I'm just writing like the same as hereditary spherocytosis. So I'm not writing here. I'm asking you now. You tell me, aplastic crisis is caused by which virus? Very good, Sahib. Parvovirus B19, right? Which cell will be more commonly affected? Which is stem cell? Erythroid, megakaryocyte, or granulocyte? Erythroid. Very good. Transient or permanent? Transient, very good, 5 to 7 days. So now you all remember those things, right? So great. So now I understood aplastic crisis is caused by parvovirus B19. I have discussed in hereditary spherocytosis, right? Parvovirus B19, erythroid congenital cell will be more commonly affected, but all cells will be affected. There will be aplastic anemia, and this aplastic anemia is for transient time for 5 to 7 days, right? Fine. So now we understood one thing, that most common crisis is the vaso-occlusive crisis. So tell me, what is the most dangerous crisis? That was the neat question and DMP question. Most dangerous out of these three. Most dangerous. Dangerous, life-threatening. So here we have to remember that sequestration crisis is most dangerous and life-threatening crisis. Right, so that was the question in NEET PG and DNB exam 2014 and 15, right? So that's why I wanted to let you know this sequestration crisis is again very important. I will tell you later on why it is so, why it is dangerous and why life-threatening, right? Now I will discuss one by one. Vaso-occlusive crisis. I will tell you soon, don't worry. Vaso-occlusive crisis. What are the vaso-occlusive crises? These are some important vaso-occlusive crises. I'm not writing all those that levels will be there and all these things. No, I just wanted to tell you the important point which examiner is very fond of, right? So these are the 4 important vaso-occlusive crises: hand-foot syndrome, acute chest syndrome, fish-mouth vertebra, and spleen will be removed. You remember ischemia, infarction, fibrosis I was showing you? That is the autosplenectomy, right? So hand-foot syndrome, acute chest syndrome, fish-mouth vertebra, autosplenectomy. These are the important things, right? Hand-foot syndrome means because hand and foot they are having end arteries. Hand and foot they are having end arteries. So this hand-foot syndrome is called as dactylitis, right? So now first I will write it here, then you understand. In hand-foot syndrome, because of the end arteries, there will be ischemia. Then there will be infarction of hand and foot bones. Hand and foot bones. Usually it will be seen in the pediatric age group. बच्चों में मिलेगा, right? Pediatric age group में, because of the ischemia infarction, क्योंकि बहुत पतली blood vessels हैं, end arteries हैं, and RBC will come and they will block the blood vessel. Ischemia will happen, right? And because of that infarction, what will happen? This baby will be having inflammation and severe pain. Inflammation plus pain plus edema. So inflammation, pain, and edema of the digits. So this is called as dactylitis. This is called as dactylitis, right? Inflammation, pain, and edema of the extremities, right? Of the extremities, or you can say of the hand and foot area, is called as dactylitis. Now you understood? HF क्या है? Ischemia, infarction of H and F foot, hand, foot. Right? Okay. That's short term. Actually, it's very bad thing to use short term. My professor used to scold for all these things. Your professor will also scold, right? So, but what to do? Sometimes you have to take the shortcut. Hands and foot syndrome. Hands and foot syndrome is, ischemia, infarction of the hands and foot bones. Hands and foot bones in the pediatric age group. Because of that, there will be inflammation, pain, and edema, and this is called dactylitis. This was the question in NEET exam. Dactylitis is associated with which anemia? So it is associated with vaso-occlusive crisis of sickle cell anemia. Clear? Now I will show you this picture. This picture is having a lot of information. First of all, you can see what is this? It's a sickle cell anemia. Who are these things? Adult or baby? So it is a pediatric. So sickle cell anemia is seen in pediatric age group. Who is commonly affected? Can you see this baby? Baby looks like Africo-American origin. Right, so that is the another important thing which examiner uses in exam. Pediatric age group, Africo-American origin, abnormal peripheral smear, most likely diagnosis sickle cell anemia. That was the AIMS question, which was in 2017. Right, so that is why I wanted to emphasize on this point. See, African baby, Africo-American baby, pediatrics, right? So sickle cell anemia. And what you are seeing here, the most important thing. Can you see this hand? And can you see this hand? Look at this hand. How is this hand? This hand is swollen, right? This hand is swollen because of the inflammation due to the ischemia and infarction. So this is called dactylitis. So you can see this is hand, and this is the feet. Both are having similar kind of swelling and the inflammation, right? So this dactylitis is the swelling due to inflammation due to the ischemia and infarction, right? So now understood, swelling, inflammation, ischemia, infarction is the dactylitis, which you are going to see in the sickle cell anemia. Which crisis? Vaso-occlusive crisis, right? Clear? Similarly, when they are going to affect the lung capillaries, smaller blood vessels, right? Lung capillaries will be causing ischemia, infarction. So patient will be having dyspnea and chest pain. I understood, dyspnea and chest pain. So imagine a clinical scenario. This is how our next exam will be asked. Edema because of the because of the vascular damage in blood vessel. Whenever there is an inflammation, what will happen? Endothelial gap will be increased. All the fluid will be moving outside. So there will be edema. That is part of sign of inflammation. You remember that vascular event of acute inflammation. That time I told you, right? So lung capillaries are there. Lung capillaries are getting obstructed by the sickle cell, and because of that, there will be infarction of the lung tissue. Right? So because of the ischemia and infarction of the lung tissue. So this will be causing ischemia and infarction of lung tissue. right? So I understood because of the lung capillary is obstructed, there is a ischemia infarction, and because of ischemia infarction of the lung tissue, patient is presenting with the chest pain, right? Patient will be presenting with the chest pain. So now you are sitting in your OPD. A patient has come to you who is approximately 15-year-old boy, and he says, I'm having dyspnea, I'm having chest pain, right? So it will be simulating like which one? It will be simulating to the cardiac angina. So how you are going to differentiate cardiac angina from here? Anatomy question, basic anatomy question I'm asking you, because anatomy applied anatomy question, I should say anatomy is applied here, because in how you are going to differentiate, is it angina pain or is it different from the angina? That was the question in the exam. Angina or different from the angina? Very good, very nice, Shubham. Referred pain should be present in the angina. Right? Referred pain, you will be saying, my pain is relating to the scapula, my pain is relating to my arms, but radiation of the pain will be absent in case of this one. So remember, it is not like angina pain. So remember, this is not like angina. So because of this dyspnea and chest pain, you will be having confusion. But remember, this is not like angina because there is no radiation of pain to the dermatomal areas, right? So pain, radiation pain नहीं होगा कहीं पे scapula में या फिर arms में, that is seen in angina, right? Fish mouth vertebra because of the infection, ischemia of the vertebral body, they will be having referred pain, yes, referred pain. Fish mouth vertebra you will see in the sickle cell anemia because of the ischemia infarction of the vertebral column. Autosplenectomy we will discuss, right? So can you see this? This is the sickle cell anemia, dactylitis, inflammation, edema of the hand and feet. Now look at this one. These are the three important things which I wanted to focus, right? Can you see this skull? Can you see this X-ray? And can you see this peripheral smear? So these are the three things which examiner is going to. That's what, wherever dermatomal alignment of the heart is there to the skin, they will be having referred pain to that areas, right? So these are the sickle cells. Can you see these are the sickle cells? Sickle cells are present. What is this? Can you see the vertebra? Can you see the vertebra? All vertebra are showing. I'm just marked one here. That is the fish mouth vertebra. Right? What is this crew haircut or hair on end appearance? Why it is called as hair on end? Can you see there is a perpendicular lining? See, this is the skull area, right? This is the bone, and the new bone because of the hemolysis, there is a new bone formation, right? So new bone which is formed. Now you can see they are all perpendicular to the skull bone. So these are all fine. Can you see fine gravity are there? So these are all fine bony gravity which is perpendicular to the table of the skull. So that is why it is called as a crew haircut or hair on end appearance, right? So hair on end appearance is not a very it's not diagnostic. It is very characteristic and it will be seen in many anemias. It will be seen in many of the hemolytic anemias. Right. This is all example of the extraordinary hematopoiesis you can say because of the hemolysis is going on. Because of the hemolysis is going on, that will activate bone marrow, and because of bone marrow activation, more erythropoiesis and more bone will be formed, and that is why there is a perpendicular striations of the bone is seen, and these are all bony spicules. So on X-ray you will be seeing crew haircut, hair on end appearance. So now you can see these are the three important findings: crew haircut, fish mouth vertebra, and sickle cells. Right. Here I want to tell you one more thing. Right. I think. Here I want to tell you one more thing because in sickle cell anemia, because of the vertebral column damage, they will be having osteomyelitis also. This was the again very frequently asked question in NEET and exam. What is the most common organism? Most common cause. Can you tell me what is the most common cause of sickle cell anemia osteomyelitis? Yes, always remember it is salmonella. Otherwise it is the staphylococcus aureus. But in case of sickle cell anemia, as sickle cell is the salmonella. Right? Fine. So now I'm going to, as I was telling you, vaso-occlusive crisis. In that part, I'm going to tell you about the autosplenectomy. So you can see the name itself is telling. Auto means self. Splenectomy means spleen removal. Self removal of spleen is autosplenectomy. Why? You remember what I have shown you that time when RBCs are having hypoxic condition, sickle cells are having hypoxic condition, they will express addition molecule. So because of this addition molecules, now there is a thrombi formation. This thrombi will be causing ischemia, infarction, fibrosis. So now understood, there will be ischemia, infarction, and fibrosis to the spleen. Right. So now what we are seeing here, this thrombi has been formed. Thrombi is stopping the blood flow to this distant organ which is the spleen now. So this thrombi is causing ischemia, infarction, and in the end what will happen, because this episode will be going on. This episode will keep going on. Repeatedly it will be repeated. Thrombi, ischemia, infarction, fibrosis. So in the end, this entire spleen will be removed by a thin fibrous band. Right? So thin fibrous band will remove the entire spleen, and this is called autosplenectomy. Right? Now, spleen is a graveyard of the RBC. And remember, this is autosplenectomy you will not find in pediatric age group, right? This will be seen in the adolescent or adult because it will take time. Adolescence or adult में हमें मिलेगा. Right. So autosplenectomy, because it is spleen is a graveyard of the RBC. Spleen is a graveyard of the RBC. So all RBC will be dumped here, right? But now what is happening? There is no spleen. Now there is a fibrous band. So understood, the graveyard is gone. So what will happen in the end? This will be giving a feedback to the bone marrow. So bone marrow is still producing. Bone marrow is still producing the more RBC, and now because of that, there will be this erythropoiesis. So this erythropoiesis means that erythropoiesis is not normal. So there will be random erythropoiesis. Nuclear maturation will be affected, and because of the nuclear maturation defect, some of the RBC will escape from the bone marrow, and they will come to the peripheral blood with the nucleus remnant. Right, with the nucleus remnant. So you can see here, this is the RBC, and there are nuclear remnant. Right. So what is this called as Howell-Jolly bodies? Right. So Howell-Jolly bodies are seen in autosplenectomy or surgical splenectomy also. Whenever spleen is removed, you will find Howell-Jolly body. Right. So now understood this point or not? Because of this erythropoiesis. Remember, this is a sign of this erythropoiesis. I will tell you in megaloblastic anemia also. So remember this erythropoiesis. There are so many signs. One of the signs is formation of Howell-Jolly bodies. Right? Formation of the Howell-Jolly bodies. What is Howell-Jolly bodies? Howell-Jolly bodies are nuclear remnant. So this is the question in previous year AIMS exam. Matching type of question. They are asked, what is Howell-Jolly body? So Howell-Jolly body is made up of DNA. Because nuclear remnant is DNA. So I understood. This was the question in previous year AIMS exam. Howell-Jolly body is composed of DNA. I understood. Howell-Jolly bodies are this erythropoiesis sign seen in the autosplenectomy of sickle cell anemia. So whereas you will see Howell-Jolly bodies. So remember, Howell-Jolly bodies are also seen in. So first we have seen sickle cell anemia autosplenectomy. This will be also seen in megaloblastic anemia. Howell-Jolly body can be seen in any of the hemolytic anemia also. Because all these things will be affecting. Remember, all these things will be affecting the bone marrow. So whenever there is a